Hi guys, and welcome back to my channel. Today I will be talking about how to approach an OSCE ophthalmology at medical school. So please stay tuned to learn more tips and tricks that I will pass on. The way I'm going to structure this video is initially talk about a few key points and facts to bear in mind. I will then go into the key skills that you may be asked to perform as part of a ophthalmology OSCE. I will then go into potential and likely questions that you will be asked at the end of an ophthalmology OSCE station. So the first thing is to remember, for your medical school, know the specifics about timings for each station, because that will have a huge bearing on what will be asked of you. For example, if your OSCE station for ophthalmology is 10 minutes long, then you may be asked to carry out a vision check. But if your OSCE station is only 6 minutes long, then it's unlikely that you will be asked to assess somebody's visual acuity, because it can take some time to carry out. The core skills that I will cover today in this video that most medical schools ask about include pupillary reactions, extraocular movements, fundoscopy, visual fields. These tend to be the popular ones that most medical schools will expect you to know very well. The other thing that I've come across over the past few years is different medical schools tend to approach things slightly differently. So some medical schools will ask students to carry out an ophthalmology OSCE on a real life patient. That real life patient may or may not have any abnormal findings. Other medical schools may ask for certain examinations to be carried out on real patients, and then other skills to be carried out on dummy heads, for example, with eye pictures that are inserted to mimic certain conditions. So again, it's important to try and establish from your medical school what it is that will be required of you, and if need be, speak to students in years above yourself who will be able to pass down some good, useful information regarding this. There are certain things that you must absolutely 100% ensure that you know when you enter an ophthalmology OSCE. So if you were to enter a cardiology OSCE, you would be crucified if you did not know how to listen to the heart sounds and pick up a aortic stenosis murmur. Similarly, in an ophthalmology OSCE, if you are unable to pick up on a homonymous hemianopia or an RAPD, then it's likely that you will do quite badly. So ensure that you know the basics very, very well. Remember, with all these subspecialities, with ophthalmology being no exception, the medical school would just like you to know and how to pick up these key, important, essential diagnostic signs and clues which will help you to manage the patient. They're not expecting you to have knowledge of an ophthalmology registrar, they're expecting you to have knowledge of a foundation F1 doctor. So that's important to also bear in mind. The fundal examinations, the common things that you will probably be presented with include a central retinal artery occlusion, a central retinal vein occlusion, diabetic retinopathy, papilledema. These tend to be the common fundal examination findings that examiners expect you to pick up on in an ophthalmology OSCE. Also remember with your ophthalmology OSCE to carry out the core components of any OSCE examination, that being confirm the patient's name and date of birth, ensure that they are in the correct position, ensure that you have their permission and consent to carry out the examination on them. Always begin with a generalized inspection by looking at the patient themselves and their environment. For example, are there any medications by their bedside that could indicate what condition or conditions that the patient may have? Once you have done this, again, medical schools differ. Some medical schools might ask you just to perform an eye routine on a patient. Other medical schools may make your OSCE examination very structured, and they may ask you to initially perform pupil reactions, then ask you to perform extraocular movements, and it's very structured and rigid. So again, this is why it's important to know what your medical school expects of you. If you have not been given a specific brief, then once you've done your initial inspection, if you're not required to carry out a visual acuity assessment, then you can begin by carrying out pupil reactions, followed by eye movements, followed by visual field testing, and then you can move into the examination of the extraocular surface, the external eye, and then gradually move through the layers to get to the fundus itself. Again, you need to develop a routine that works for you. It doesn't have to be set in stone, it just needs to be efficient. You need to know it very well, and it needs to be in line with what your medical school expects of you. Again, as with any OSCE station, you will always complete the examination by, as well as stating your findings and how you will investigate the patient further, you should always state other tests that you would like to carry out, which include things such as imaging and blood tests. Specifically with respect to ophthalmology, I would say something like, to complete my examination, I would like to carry out a dilated fundal examination with the aid of an indirect lens and a slit lamp. I would also like to check the patient's intraocular pressures, and I would also like to carry out a automated visual field test. It goes without saying, depending on the findings that you pick up on during the examination, you may want to complete your examination by carrying out additional things. For example, if the patient has diplopia, then you would ask for an orthoptics assessment. And the final key thing to remember before we go into some of the specific skills is, when you're examining a patient's fundus, have a structure. Don't call out the glaringly obvious hemorrhage or papilledema that may be present. Initially focus on the disc, then focus on the blood vessels, then focus on the macula, then focus on the periphery. The diagnosis may be very obvious and apparent, but if you just dive into what the diagnosis is, you may miss some of the other subtleties and other subtle signs that may be present in the picture. The flip side of this scenario is, if you are completely unaware as to what the diagnosis is, by describing systematically what you see, you may inadvertently end up realizing what the diagnosis is by the virtue of summarizing what is present in the fundal picture or the fundus of the patient that you're examining. We'll now go into the specific skills that your medical school may require you to perform during an OSCE examination. The first one is vision. So with vision, some of the key important points to remember are, firstly, are you doing the test at 3 meters or are you doing it at 6 meters? Remember, if it's at 3 meters but you have a mirror, it effectively becomes 6 meters. That then becomes the top of your fraction. If it's done as 3 meters, then obviously 3 becomes the top of your fraction. Important to also ask at the beginning of the consultation whether the patient wears glasses or they wear contact lenses. If they wear glasses, ask them, are they glasses for the distance or are they for reading? Because you do not want to ask them to put their reading glasses on to read the distance chart. They won't be able to see much at all, potentially. If they've got bifocals on, then, or varifocals, then it's fine to ask them to read the distance vision chart. You will test each eye in turn. You will usually cover the eye with an occluder of some sort, and you will ask the patient to read from the top of the chart down to the bottom of the chart. If you want to establish any further visual potential, you can pop up what's called a pinhole, and that will help you to establish any further visual potential. In an OSCE, I very much doubt you'll be asked to carry out a pinhole examination in addition to a visual test examination, but you could say to complete my examination I would also use a pinhole at this stage. Once you have tested one eye, you will then move across to the other eye and repeat the same task. For the benefit of time, in an OSCE setting, rather than asking the patient to read from the top of the chart down to the bottom of the chart again for the second eye, you can simply just ask them to go straight to the lowest line that they can see, and that way you will save both yourselves and them time and effort.
So today we're joined by the very glamorous Mrs. Jones, who is going to be helping me to demonstrate some of these skills. The first skill we're going to talk through is assessment of visual acuity. So I'll talk about the intricacies after, but essentially Mrs. Jones wears spectacles for the distance, which she has on at the moment. So with those specs on, I'm going to ask her to kindly cover her left eye with the occluder, and then we're going to ask Mrs. Jones to read from the top of the chart down as low as she can.
A-O-E-H-L-A-N-T-C-O H-L-A-O-T N-T-O-L-A-E. And I can't see an awful lot of the next line.
So at this point it's important to note down what the patient has just read, which is 6/9, because this test is being performed at 3 meters with the aid of a mirror, which makes it 6 meters. So then I would ask Mrs. Jones, are there any letters that you can pick out on the line underneath?
No, not really. I can see shapes, so I can see whether they're like an L or an F, or a rounded shape like an O or a D, but I can't really see them clearly.
Okay, that's fine. So I would then record the final acuity as 6/9. This occluder that Mrs. Jones has in her hand currently does not have pinholes, but if it did, or you had a pinhole, which is unlikely to be present in your exam, then you could try and establish whether there's further scope for improvement with the aid of a pinhole. So I would record the right eye as 6/9, and now I'm going to ask Mrs. Jones to repeat the same thing for the other eye. In the real world setting, you can do this, and in an OSCE setting, but because we've established the task and what is required of Mrs. Jones for the right eye already, you can, for the purposes of time, just ask Mrs. Jones to go straight to the lowest line that she can read, as opposed to starting at the top and going all the way back down. So Mrs. Jones, what's the lowest line that you can read with your left eye?
So it's N-T-O-L-A-E. I can see a few of the letters below. L.
So if you ask the patient to read the letters on the chart and they read A-O-E-H-L-A-N-T, then this could be recorded as 6/18 minus 2, because they read 2 correct letters on the 6/18 line. They read N and T, but they got these 2 incorrect. So you could record it as 6/18 minus 2, or you could record this as 6/24, which was the last full complete line that they read, and in addition to that they read 2 extra letters, so you could record this as either 6/24 plus 2 or 6/18 minus 2. So it means the same thing, so ensure that you understand this concept. If the patient was unable to read the top letter, then you need to halve the test in distance. So if they're unable to read the top letter at 6 meters, you would then move them to 3 meters and ask them to repeat the task. If they were still unable to see it, you would then move them to 2 meters. If they were still unable to see it, you would move them to 1 meter. If they were still unable to see that, you would ask them to count how many fingers you were holding up. If that was still not possible, you would then carry out hand movements and ask them if they appreciated you moving your hand. And if this was not possible, you would then finally move on to, is there any perception of light? And if not, then they are no perception of light. So that's the gradation of and the format you go through in terms of trying to establish somebody's visual potential if they are unable to read the top letter on the chart, eye movements. For this, you will be sat directly in front of the patient. You will ask the patient to look at a chosen target, which can be either the end of your finger, it can be the end of a pen. Ideally, it should be a pen torch so that you can look at and interpret the corneal reflexes. You will then ask the patient to keep their head still at all times and follow your target simply with their eyes. You need to have a system for how you do this. So I generally like to assess the horizontal movements first. I then go across to the diagonal ones, both opposite sides, and then I do the other diagonal movements, and then I do straight up and down. However you do this, you need to be comfortable with it and you need to be able to interpret the findings. Some people advocate the star method, some people advocate the H method. Ultimately, you need to do what works well for you. It's important to also ask the patient to report to you any pain or double vision that they may experience during the performance of this test. If they experience pain and double vision in a certain position of gaze, you would then note this down in your findings. Not in an OSCE setting, but in a real life setting, you would then tell the examiner that in the positions of gaze where there was a problem, you would perform a cover test. And also, to complete your examination, you would ask for an orthoptic assessment. Before you begin your examination, also remember to pay very close attention to certain clues that could indicate what the underlying pathology is. So does the patient have an abnormal head posture? This could be a head tilt, it could be a face turn, or it could be a chin elevation or depression. All of those things could give you different clues as to what the underlying cranial nerve palsy is. Also, has the patient come in wearing glasses that have Fresnel prisms attached to them? You need to be very vigilant because these clues could be fundamentally important in helping you to understand the diagnosis. In this short video, I will now demonstrate a brief overview of how to perform the extraocular movements examination. The key points are, just remember to ask, to observe, and to pay very close attention, looking out for any underactions, any overactions, any pupillary abnormalities, any changes in the vertical palpebral aperture, which is the difference between the distance between the upper and lower eyelid, and whether this changes in different positions of gaze.
The next skill we're going to demonstrate is eye movements. So for this, it's important to usually ask the patient to take their spectacles off to try and reduce any prismatic errors being introduced in the peripheral aspects of their field, which could cause double vision. The next thing I would then ask the patient to do is to kindly fixate on my target, which in this instance is going to be a pen, but ideally you should use a pen torch so that you can appreciate the corneal reflexes. The next thing to reiterate to the patient is to keep their heads as still as possible, to follow the target into all positions of gaze, and to report any pain or any double vision. So is that okay, Mrs. Jones?
Certainly.
Thank you. So if you could follow the target nice and smoothly just with your eyes. So it's important to have a system with this. So that's up gaze. We then move to down gaze. It's quite easy to see Mrs. Jones's eyes in the inferior position, but if you were struggling, you could just elevate the lids. I'm then going to assess the horizontal eye movements and then come across to the other side and then come to the lateral gaze positions. And it's important to do diagonal positions so that you can appreciate any asymmetry. Did you experience any pain or double vision, Mrs. Jones? Perfect, thank you.
In certain eye conditions, saccadic eye movements can become slower, such as in myasthenia gravis. To assess saccadic eye movements, what you would do is provide the patient with targets. So if I was assessing horizontal saccades, I would provide the patient with 2 horizontal targets, and I would ask them to rapidly alternate fixation between the 2 targets. So if I perform this on myself, that's how you would do it. Then you would do the same thing but with 2 vertical targets. So if we repeat the same thing. So hopefully my saccadic eye movements are normal. Skill is pupillary movements and reactions. So I will demonstrate this shortly with a video, but the key things to remember here are the light needs to be bright, the brighter the better. The room needs to be adequately illuminated, usually quite dim lighting, so that you can appreciate pupillary responses better. Note down the shape of the pupil, the size of the pupil, and then you are going to carry out the pupillary examination. Also look for other subtle signs such as, is there ptosis, and can you appreciate the potential anhidrosis that may be present. You will be carrying out a direct, a consensual and a RAPD examination of the patient's pupil. Ask them to look into the distance at a target and ensure that you stand to the side of this distance target, because you do not want to be inadvertently stimulating a near pupillary response. You will then shine a bright light into the right eye initially, or the left eye depending on which side you start on, and you will appreciate whether there is a direct pupillary response followed by whether there is a consensual pupillary response on the contralateral side, and then you will check for an RAPD. The key points with respect to an RAPD are ensure that you swing across briskly, and the best tip that I was taught was swing across and in your mind just count 1, 2. So you would go onto the right eye and count 1, 2, and then you'd come across and count 1, 2, 1, 2, 1, 2, and you're looking for clues as to whether there's an RAPD. Remember, when you're carrying out this in OSCE setting, it's highly unlikely that you will have an acute presentation such as a uveitis or an acute angle closure glaucoma. So you need to factor this in mind, but what you may get is questions about what would you do if you found this. So that's why it's important that you know some common associated pathologies with abnormal pupils, such as Horner's, such as a third nerve palsy, such as an AD's pupil. So it's important that you know these well.
Okay, so the next skill we're going to demonstrate is pupillary reactions. For this, it's important to have quite a darkened room in order to allow you to see the pupillary reactions quite easily. If you were to have a fully lit room, then reactions to light would become very difficult to appreciate. So the important thing about this is to ask the patient to look into the distance at a set target, and then use a very bright light source. In ophthalmology clinics, this is typically done with an indirect ophthalmoscope, but in this setting I'm going to use a direct ophthalmoscope. So the first thing I'm going to do is check the direct light response in the right eye, which is present, and then doing the same thing, I'm going to look at the consensual light response in the left eye, which is also present. I'm going to then repeat the same thing for the other eye. So direct, and then consensual, and then I'm going to now do a check for an RAPD. So it's important to come across, hold for 1, 2, hold for 1, 2, hold for 1, 2.
Next favourite skill that medical schools ask candidates to perform is a visual field assessment. This is a favourite because this can be essentially faked in terms of findings. So one can easily fake the fact that they have a homonymous hemianopia or a bitemporal hemianopia. So know the common visual field abnormalities and what they indicate very well. In terms of a routine, you need to ensure that you are sat in front of the patient, ensure that you are the same eye level as the patient. You can perform this in several ways, but the method I like is when you essentially compare your visual field to the patient's visual field. So I would ask initially the patient to look into my right eye, and they would cover their left eye. I would either close my left eye or cover my left eye. So essentially I would be looking directly into the patient's right eye, and they would be doing the same thing as me for their left eye, i.e. covered or closed. I would then move a target from a position of where I cannot see it to where I can see it, and I would ask the patient to tell me when they first see it. I would then come across into the middle and cross the vertical and horizontal midline, and after the patient had initially seen the target, I would ask them to tell me if it disappeared at any point, because that could indicate a scotoma in their field of vision. So don't just stop wiggling your finger or moving your target as soon as they say that they can see it, because they may be able to see it at this point, but as you bring it closer, it may disappear. You would perform the same task in all 4 quadrants for one eye. You could then, if it wasn't picked up during testing, try and establish whether you can detect their blind spot. So you do this by going temporally at about 15 degrees and asking them to tell you if your target disappears and when it comes back into view. You would then repeat the process for the fellow eye. I got to mention which you must ask at the very outset of this particular examination is ask the patient when they are sat directly in front of you, A, whether they can see your face, and B, whether any parts of your face are missing. So in the case of glaucoma, the peripheral aspects of their vision and therefore your face may be missing, and in the case of macular degeneration, the central portions of their vision may be missing. It's important you establish this before you begin testing their visual field, because it can save you a lot of time and confusion. Once you have carried out your visual field assessment, remember what I said, the common things are common, and the things that they're expecting you to pick up on and then subsequently ask you questions about are quite classic things. So know how to detect a bitemporal hemianopia, for example, because then the questions quite nicely lead into a pituitary pathology. So if the patient is missing things in a certain aspect, then think to yourself, what could this indicate in terms of classic visual field findings? So the next component of the examination that I'm going to be talking about is how to examine the external eye and then move it into the internal eye and the fundus. We are currently passing through COVID times, so it was difficult for me to actually find a volunteer to demonstrate this on. So therefore I am using the beautiful box of tissues that have 2 eyes drawn on them. Can I just declare that I have no financial interests in advertising this Boots tissue box. It was just the one that was present at the time of recording this video. So with respect to external examination, the first thing to do is have a broad beam and a wide beam, and with that you will initially look at a distance of about arm's length at the pupils and note any obvious abnormalities. You would look through your ophthalmoscope and identify whether there are any obvious opacities within the lens. Is there a good red reflex? If there's not, is there a cataract, for example? Once you've done this, you would then move in closer towards the patient, and you would begin by looking at the lids and lashes. So I would scan whichever way you prefer, from in to out to in, and it's important to cover the eyelids initially. And you can do this on both sides. You can either do structure by structure, bilaterally, or probably more systematic would be do one eye and then move on to the second eye. After looking at the lids and lashes and looking for things such as blepharitis or any abnormalities in position of eyelids, I would then ask the patient to look up, down, left and right and observe the conjunctiva/sclera for any abnormalities. Once this had been done, I would look at the clear cornea, and usually you would not be able to appreciate anything unless there were any abnormalities. Then look at the iris details, look at the size of the pupil, are there any obvious glaring abnormalities. You would then change the focus of your ophthalmoscope. So initially you would be on quite high magnification, potentially around 10, and that's +10, so that you could see the external eye, and then when you get closer you could either increase or decrease this according to what it is you're trying to appreciate. And then to look at the lens, usually you need to be between around 10 and 14, and you need to be quite close to the patient at this point. So you have finished examining the external eye, you will then move to look at the fundus. So I would start off on 0 initially on the ophthalmoscope. So you can see both of these. So you can see both of these are set to 0. That's including the top one and the bottom aperture. You need to be familiar with your ophthalmoscope to do this, and if you're not practiced, if you do have a prescription, i.e. you wear glasses, you can dial that in at this point. So my prescription is -3, so I can dial in -3. So then I'm able to perform this examination without wearing any glasses. Sorry if this is not projecting very well. Then you would start off typically temporally looking through your ophthalmoscope, and you would come close to the patient, and ideally if you approach at this angle about 15 degrees temporally, you should hit the optic disc. And remember what I said, you would carry out a systematic approach, initially looking at the disc, then moving your gaze to look at the superior vessels, then the inferior vessels, and then you would come across to the macula. You would then do the periphery. To examine the peripheral aspects of the retina, you would ask the patient to look up, and you would move in this direction. You would ask the patient to look down, and you would move in this direction to examine the inferior fundus, and similarly to examine the nasal fundus in the right eye, you would ask them to look to their left, and you would move in the opposite direction. The key things with ophthalmoscopy are ensure that you are as close to the patient as possible. This will afford you the best possible view. Currently in COVID times, this probably will not be happening, so in real life and in your OSCE station, you will probably be asked to examine a dummy head that has a picture of a pre-selected pathology in the back of it. So that covers the skills section of the OSCE examination. I will now go on to talk about some of the common topic areas that you can expect questions on. So to ensure that I do not miss out anything in this section, I have written these down in my phone, so I will read them off. So common questions include causes of red eye, grading of diabetic retinopathy, causes of Horner's, signs of thyroid eye disease, interpretation of visual field defects, causes of loss of vision, both sudden and chronic, types of macular degeneration, dry and wet, and questions related to those, signs of hypertensive retinopathy, causes of ptosis, causes of a dilated pupil, What are the differentiating features between a melanoma and a choroidal nevus? PRP scars and implications for driving, for example, retinal detachments, central retinal artery and or vein occlusions, pituitary tumours, 3rd, 4th and 6th nerve palsies, and causes of cataracts. These questions may be in the form of just simple verbal questions, or they may relate to a specific photograph and then questions are asked based on those. So it's important to be familiar with all of these and know your syllabus very well. That brings me to the end of this video about an ophthalmology OSCE station at medical school. We've covered a lot of material, so if you have stayed tuned until the end, I thank you so much for your attention, and I hope this video has benefited you. To summarize then, we initially spoke about some common things to be aware of, such as timings for your medical school and what your medical school actually expects of you. Secondly, we then dived into some of the nuances about how to perform the core common skills pertaining to an ophthalmology OSCE, and we finished off by just mentioning some of the key topic areas that will potentially be asked about. If you have found this video useful, then please do share it with your colleagues, and please do hit the like button, the subscribe button, and stay tuned for more videos. This channel is intended to aid medical students, members of the public, other professionals, and I hope there's something useful for you on this platform. But in order for my platform to grow, I do need help and support from individuals such as yourself. You may think that clicking the subscribe button is not a very big deal, but for small channels such as myself that are trying to establish a niche on this platform, it would mean a massive amount. So please do kindly hit the subscribe button and comment and share what you think I did well, what could be improved, and any future videos you would potentially like to see. I would love to hear from you. Thank you so much, and good luck for your OSCE. Remember, be confident, and if you know your things in terms of your knowledge and you've practiced well enough, you should be absolutely grand. Thank you so much.